Sorry, my apologies. There was some technical error. So we have discussed a lot about the characteristic of mesothelioma and the diagnostic as well as role of surgery in mesothelioma. So usually mesothelioma is a disease of elderly with a presentation at latter stage of the life. So it's an aggressive malignancy with overall poor survival outcomes. The 5-year survival outcomes range in the it ranges in the 10%. If we see a stage-wise outcome, the stage 4 disease has a median OS of 14.9 months. We have discussed the etiology and diagnostic things. So asbestos is the main etiological factor. Clinical presentation, as we all know, chest pain and dyspnea are most common symptoms. Patient may present with pleural effusion and rarely localized mass. So it is challenging to differentiate between the metastatic pleural disease and the malignant pleural mesothelioma. So we have discussed this part. We have discussed the role of imaging, histopathological classification. We have discussed the ISC thing. So at least 2 positive mesothelioma markers and 2 negative adenocarcinoma markers are required for diagnostic accuracy. There are some genomic studies going on. Loss of BAP1, loss of CDK2, and loss of MTAP have been associated with mesothelioma, but they have no currently they have no role in diagnostic. So in management algorithm, we have seen if patient is suitable for multi-modality treatment, we consider for macroscopic complete resection and chemotherapy. So we will move to systemic therapy in advanced disease. I will be covering treatment in first line, maintenance therapy, recent advances, and the further lines of therapy. Despite the various efforts, we have been not able to achieve promising results in mesothelioma. In resectable disease, we have some trials where induction chemotherapy has played a role and it's a standard of care. So we have this trial by Krug of pemetrexed cisplatin, where the response rate was 32.5% and the median OS was 60.8 months. So this is a guideline for systemic management. So if patient is suitable, is unsuitable for multimodality treatment and is being planned with palliative intent treatment, we have a immunotherapy in first line, which includes nivolumab plus ipilimumab. If PS is bad, we can choose best supportive care. If patient is not feasible for immunotherapy, we have systemic therapy in the form of pemetrexed and cisplatinum or pemetrexed and carboplatinum for cisplatin unfit patients, followed by plus minus maintenance gemcitabine. Also, we can use bevacizumab along with pemetrexed and cisplatin. At disease progression, we use single agent chemotherapies that include vinorelbine, gemcitabine, or we use single agent immunotherapy, and there is a new data coming on gemcitabine and ramucirumab. I will be discussing in further slides. So this is the this was the first trial for pemetrexed and cisplatin in unresectable mesothelioma, where patients were randomized to receive pemetrexed and cisplatin against cisplatin. The primary endpoint was OS. Secondary endpoints was response rate, quality of life, and toxicity. So we achieved a median OS of 12.1 months in the pemetrexed cisplatin arm versus 9.3 months in the cisplatin arm with a hazard ratio of 0.77. So this trial, neutropenia was the most common toxicity, followed by nausea, vomiting, and fatigue. Other platinum that were tried, pemetrexed and carboplatin, the overall response rate was 18.6 months and 12.7 months. It was comparable. We use carboplatin in the setting where patients are ineligible for cisplatin therapy. This trial was ralitexate and cisplatin. Here, the overall response rate was 24% and 1 year OS rate was 46.2%. So this is a study of frontline PEMCIS and bevacizumab in unresectable mesothelioma. Here they use pemetrexed cisplatinum along with bevacizumab, and in other arm, they used pemetrexed and cisplatinum. 6 cycles were given, and bevacizumab was used as a maintenance therapy. No crossover was allowed. So there was no OS benefit associated with the bevacizumab maintenance. On subgroup analysis, sarcomatoid histology favored responses to bevacizumab compared to epithelioid histology. Other maintenance therapies, those were tried, are pemetrexed and gemcitabine. Both drugs were evaluated in trials. There were modest responses were maintained, but there was no OS benefit in the final analysis. We come to the role of immunotherapy. So Checkmate 743 trial, this trial, it's a open label phase 3 study of nivolumab plus ipilimumab in mesothelioma, where unresectable mesotheliomas were randomized to receive nivolumab ipilimumab for up to 2 years versus standard of care, that is pemetrexed and cisplatinum. Primary endpoint was OS, and secondary endpoints were overall response rate, disease control rate, and PFS. So baseline characteristics were comparable in both the arm. The Nivo arm had 76% patients of epithelioid histology and 24 patients of non-epithelioid histology, whereas 80% were PDL1 positive and 20 were PDL1 negative. So primary endpoint, we have got the 3-year OS update for this study. So at median OS was 18.1 months versus 14.1 months with a hazard ratio of 0.74. When we analyzed this data at the end of 3 years, the OS was 23.2% in patients who received immunotherapy versus 15.4% in patients who received chemotherapy. On subgroup analysis, female patients having non-epithelioid histology and PDL1 positivity had better response compared to.
Hi, Dr. Sunil. Dr. Adesha, could I request you to wrap up in next 1 minute? We are running a little late.
Yeah.
Thank you.
So this is a second study, of confirmed study, which evaluated nivolumab as a single agent in the first line, where it was compared with the chemotherapy, and we have a positive results with PFS of 3 months versus 1.8 months and overall survival of 9.2 and 6. Versus 6.6 months. So it's a promising study. In second line, we have option either we re-challenge with pemetrexed and platinum if the recurrences are more than 6 months. Other agents which can be used are single agent gemcitabine, venurelbine on pemetrexed. These have shown modest responses, but there was no OS and PFS benefit. Pembrolizumab was tried in phase 2 Keynote 150 study in second line, where 118 patients were enrolled. 8% patients has a objective response. Median OS was 10 months. This study showed a promising activity of pembrolizumab. This one trial is Promise Meso, where pembrolizumab was used against standard of care in second line, and there was no OS benefit. So tremelimumab was tried. It has a no rule. It has found no OS benefit. Thank you.